if you can just, thank you, Jen. If you can just do, if you can identify yourself and the community you're with, and starting with Dover.
Jason Belmonte, Dover, present.
Great, thank you. And now Medfield.
Carol Reed, present for Kathy Thompson.
Thanks, Carol. And Needham. Ed Cosgrove here. And Sherburne.
Daryl Beardsley from Sherborne.
Great. And now we're going to do introductions of others present, and I'll start with me, Carrie Janelle, manager for the Shared Services Program for Charles River Public Health District. And starting top left, Jen Casey.
Good morning, Jen Casey. I am the admin specialist for Charles River Public Health District.
And to my next to her right, Emily Delaglio.
Yep. Emily Delaglio, public health nurse in Medfield.
And then Tim McDonald.
Hi, Tim McDonald, Director of Health and Human Services in Needham.
Jen Gangadarin.
Morning, Jen Gangadarin, Regional Public Health Nurse.
And then I see Sherburne Board of Health.
Hi, my name's Sarah. I'm the Board of Health Administrator for Sherborne. Sorry, my camera's
Good morning,
off.
Sarah. Nice to see you. Okay, and there's no one else present in the meeting for public comment, so we can dispense with that. No members of the public present. So then the next order of business is approval of minutes. I sent out 4 sets of minutes to the advisory board list, and I'm wondering if folks had an opportunity to review them and if anyone had any questions. The first one was the May 29th meeting. Any questions or comments about those? And I'll run through the list of the dates and then see if there are any changes, and if not, then we can go back and do I'll ask for a motion to approve. So May 29th, any comments? Okay, hearing none. June 10th. Any comments? Nothing. June 17th. No comments, seeing none. And then last one is July 22nd. No comments. Okay, great. Then I would, if anyone was willing to make a motion to approve the minutes for May 29th.
I'll make that motion.
Okay, motion from Ed Cosgrove. Is there a second?
Second.
Jason Belmonte seconds from Dover. So then we'll do a roll call vote, and it's to approve the minutes of May 29th, June 10th, June 17th, and July 22nd, all 2025. We'll do alphabetical again. Dover.
Yes.
Medfield.
Yes.
Needham.
Yes.
And Sherburne.
Yes.
Great, so the minutes are approved. Thank you all for the time reviewing those. And now we can roll right along into staff reports and updates. And I'm going to turn to Jen Gangadarin first for public health nursing.
Morning, everyone. So the nurses, I think I mentioned this when we met before, but we have started meeting regularly. We had our first meeting earlier this month, which is basically a space for us to share knowledge, to figure out where we can support one another. And I put it out to the nurses from each of the towns because I wasn't sure how frequently people would want to meet. And it was decided that we would start out monthly. So our next meeting will be August 26th, I think. And what we decided at that meeting was to start tracking all of our work. So I have a number of spreadsheets that we're all entering information, like how many clinics we're having, how many MAVEN investigations, that sort of thing. And we also are collaborating on vaccination efforts. We have, so Dover, Sherborne, and Medfield, to my knowledge, are using some outside pharmacies for some of the flu clinics. In addition to that, Needham has offered to host clinics in those towns. And Emily and I just had a quick email exchange this morning that Medfield may or may not take us up on that. And it sounds like Dover and Sherborne are set for now. And the idea is that we'll all work together in those clinics to make them happen. Some other things I've been working on is just creating some documents, some standard operating procedures for the shared services around vaccines and coverage and that sort of thing. So that's kind of what we've been up to.
Great, thanks very much, Jen. I know when I was on the Medfield Board of Health meeting, I think it was last week, there was discussion about, hands-free CPR. I raised it, they were talking about Medfield Days, and I don't know if that would be something that folks will wanna include, but I know they're very interested in it, and I know folks are interested in all the work that you all are doing. So thanks for getting the group together, and we'll have it as a regular part of your report in for the monthly meeting will be, what's happening with your public health nursing group, and you can make recommendations to this group or ask for discussions about things, and then we'll bring it that way, and that this advisory board may turn and say, hey, nurses, can you all consider this? Tell us about this. So I think it's nice to have the group, now that you have multiple people and you can make a group, I think it's nice. It'll be great for everyone to have that cycle and sort of formal structure to run stuff through. So thanks for spearheading it.
Yeah, I should also add, Carrie, I forgot to mention when you said hands only CPR. I wish it was hands-free, but Gail and I did a clinic, which Emily joined us at. I think I mentioned that too last time, but on July 15th in Sherborne at Town Hall, we had about 20 people who attended. And there was a lot of interest in doing that again, it sounded like. So we're happy to do that in any of the towns if that's something that the towns would like.
That's great, thank you. And I know there are a couple of hands up. I have Daryl and Carol. I'm not sure which one was first. I'll go alphabetical and go with C, Carol, if that's okay.
Hi, thanks so much, Jen. I am just so grateful for this whole regional nursing effort. You were saying you all decided to track your work. Number of clinics, number of MAVEN investigations. Are there other things that you're all tracking? And then will that be in a regional monthly report, as one region or by town?
Yeah, great questions. So I am tracking lots of things, number of clinics, number of home visits, vaccination clinics, how many vaccines we actually give. Are there any health fairs that we attended, CPR clinics? So basically, I'm trying to track the number of things that we're doing, and in addition to that, the number of people we're serving. And I am tracking it. The way that I have it set up is that each nurse can enter the numbers for the month, or they can send it to me and I can enter it for the month. And then I just have sort of a running total for the region.
Okay, I have another question. So it will be the regional total.
Yes, it's the regional total. And
Yep.
I also have the town totals.
Okay.
But yes, like for my reporting purposes, as the regional person, I'm looking at, the total number.
Yep, that's awesome. And you were, I think I got this, you offered to have flu clinics in each town that would be for flu and COVID, or?
The big question these days. So I was on the Public Health Council meeting for 3 hours yesterday, where they discussed sort of the future of vaccine recommendations. And right now, the guidance for COVID is 65 and over or high risk. And so those are the guidelines. I think we're going to stay tuned to see what happens with COVID recommendations. But my understanding is that about 60% of the population is considered high risk. They cited on a state meeting last week that inactivity is high risk. So I don't know that we'll be able to offer COVID to everybody. I think for now, I know I spoke to Ginny about it yesterday. We're just planning to do flu and have some COVID ordered for high risk folks. But the clinics themselves, I think, just flu.
Okay, and then if you did a clinic in our town or any other, do you order? And then do people register on color, or how does that work?
Yeah, so yes, Needham would order the vaccine. Needham would essentially host the vaccine clinic, which means that people would register in color. Needham would bill for the vaccines that way. Emily, I know we talked a little bit this morning about coordinating sites and dates and that sort of thing. So that part of it would fall on, Emily or Gail. And then, Ginny would be at the clinic, and I probably would be, and whoever else is, Emily or Gail, depending on the town.
Right, so you would order the vaccine and
Mhm.
bill for the vaccine, but host if each town wanted it in their town,
That's correct. Yep.
and flu only.
For now,
Yeah.
we're
And-
awaiting guidance every day. We're hoping.
And yeah, thank you.
Uh-huh.
Thanks. Daryl?
Hi, actually, maybe some of what you just discussed might kind of resolve some questions I have. So in Sherborne, had been doing the flu clinics for decades. And in 2024 was the first time we hadn't had one in a very long time. The board wanted to have one, but there were just circumstances beyond our control that did not happen. And then we weren't quite ready this year because we'd have to reassemble our MRC and do other things. But it sounds like this would help us over that current hurdle. And I haven't had the chance, but I'll bring this up at a meeting to go over with the rest of the board whether they still like having flu clinics in town. And we certainly saw lots of benefits to doing it in the past. I do think with the new pharmacy in town and the system set up during COVID that they are better equipped to provide some of the things that we did that people were having a hard time getting in other venues. But so I guess that's by way of saying right now, I think we're going to be flexible on that. And I'm sure Gail is working with you on that. I haven't had a chance to talk to her about this issue, but
Yeah,
we
Gail,
have
who's on
experience.
vacation this week, said she thought that Sherborne would use Pine Hill Pharmacy. But I'm not sure, when she gets back on Monday, we'll meet again and just sort of firm that up. But certainly the Needham option is open to everybody.
Right,
Okay.
and I think that's the important piece is that it's an option, right? This is something that Jen and the folks have come up with and said, yes, this is possible. This is a way to address needs. It may be that everybody wants it. It may be that everybody doesn't. It might work for you with your existing solutions, but we're looking at it from a regional perspective and how can we help? And this is the way. And we're thankful to Needham for being able to sort of take that lead and do the ordering and get us moving forward. So,
Right.
and I think each of the
right now.
nurses, sorry.
Oh, I was saying we're just in a state of flux right now because
Yep.
we had a well-established procedure and then we didn't. So we're just figuring out what the next steps are.
Yeah, and I think, so I think probably, I think Gail would be coming back to the board, to talk to each of the boards and kind of say, this is an option. Is this something you wish to do? Just like Emily would be doing in Medfield. This is an option. Is this, something you'd like to do? Maybe they're providing a recommendation to y'all. Maybe they're not, and we stand ready to support and organize. and here's a way to make it happen, given that everybody's in a different kind of state of flux. So, okay. Is that everything on that? Anything, any other questions for Jen about nursing? Thank you, Jen. So then, next, sorry, flipping my pages. So the next one is environmental health, and absent a regional environmental health agent, I get to report out to y'all. I have not convened another meeting of the working group of the environmental health agents in our communities. That I had hoped to organize, but with work plan work and other things, I have not done that. So we met last, I think, in the end of May, and we will be reconvening that group. Yeah, I hope to get something going in September. It was a productive group. I think all of the folks enjoyed it. It was an opportunity to look at the workforce standards, the performance standards, talk about common issues like could we create a common application, and has anybody dealt with this kind of question? So that is on hold right now because we're hiring. We did post the regional environmental health agent position. It was open for 2 weeks. We received 24 applications. And a thank you to Jason, because Jason Belmonte's been great support, as he had offered, and as he always does. He reviewed the resumes with us. Jason will be part of our interview committee. Of the 24, we identified 6 people on a short list. I will say that we didn't get great, we didn't have a lot of folks that had direct experience, let's put it that way. And Jason maybe will want to say more about it. But we pulled some folks that we thought might be appropriate. We've got 2 interviews scheduled already for Monday. Thank you, Jen Casey, for getting us scheduled for that. We're waiting to hear. One of the shortlist people has withdrawn, and we're waiting to hear from the other 3 to see if they will be available or interested in interviewing. So those interviews will be Monday, and the panel is myself, Jason Belmonte, and Tara Burge, the Assistant Director for Environmental Health here in Needham. She's agreed to participate and support us for this. So we are hopeful that, well, we'll see. We're going to do some interviews, we'll see if we can make a match. Jason, is there anything you want to add on that?
Yeah, I guess the only thing I would add, Carrie, is to your point about some of the experience we saw amongst the applications. Yes, there was a large number of applicants. What'd you say? There was about 2 dozen.
Yep.
Wasn't a lot of direct health department experience, which I think is really important for this type of role. So I think we're going to kind of have to, we've gone through and selected about a half dozen or so candidates we're going to move forward with. A lot of good other experience that we've seen for sure. We're just going to have to decide, out of these folks, who's going to be the best fit. Certainly a lot of what we do can be trained or, taught. But, we'll do the interviews and see how things shake out.
Right. Thanks, Jason. Yeah, I think, you're right to your point about the additional, the other experience. We had folks, who would have great maybe epi experience, or great, they had done a lot of work in labs, but not any local government experience, not any inspection experience. And that's going to be tricky. And I think one of the things that our panel will talk about, and we'll talk with this advisory board about, is where we started this conversation, I think last time, where do we want this position to be? Is this a position, this regional health agent, do we want this to be someone that we're training, or do we want this to be someone that has a higher degree of skill that, can be there to support all 4 towns? My personal preference is that be the second. But I don't know if circumstances will allow us to have preference. But we'll have that conversation. I'm grateful to have Tara and Jason participating because we can have a good solid conversation about what do we have to work with here, and, you know, should we, I think one of the questions will be, do we feel like we need to go back out, right? It's not always easy to hire it's not easy to hire ever, but summertime sure can be tricky. So, well, one of our questions will be, would it be appropriate to go back out in September when people are back from vacation and, you know, thinking more about work? So Jason, I see you thinking.
Yeah, no, I was just going to add to that. You know, going back to what I just said too, we also shouldn't feel like we have to settle on somebody if we don't feel like any of these people are a fit.
Yeah.
You know, I don't want to shoehorn it just because we're in this position. Summer's a really hard time. It's just crickets in terms of postings, hirings, all that stuff. Yeah, so maybe we go through the interviews and say there really isn't anyone who is overwhelming to us, so we'll reconvene in the fall and we'll get a completely different crop of candidates and go from there.
Right. Thanks, Jason. Ed?
Yeah, I think that if this position was in a local board of health, you could take one of those people and they can learn. But I think where we're looking for someone who's going to work with, you know, several different boards of health, and I think they already need to know the basics of what they're doing so they can go out.
Yeah.
It can be added learning, but I think they need to know the basics.
Yeah, thanks for that feedback, Ed. I think that makes good sense. Carol?
Yes, thanks. And thanks to Jason and all of you for this work. I want to clarify. So you identified 6, 1 withdrew. And did I hear it stated that no of these 5 have inspectional, they're not RS? Is that?
That's correct. There is one candidate who was in public health prior and has shifted to another area of municipal government, municipal government work, and is interested in coming back to public health. But yes, no, we don't have any experienced folks.
So to me, and I'm the third in line here from Medfield, but I've been around this work, being that I worked in Needham for 16 years. To me, this position, that's the priority, right? To have someone who can do what Jen's doing, a nurse who's coordinating nursing among town nurses. And I know that this position is half-time for the training hub, but to me, I thought this person is that experienced registered sanitarian, environmental health person that can coordinate and those services. Is that not correct on my part?
That is correct, Carol, but I think that just like we do with any hiring, it's kind of that's what we want. Now let's go into the market and see if we can get it. And we have to identify if the market is going to give us what we want. And then we'll have to weigh the decision of, okay, at what point, do we stay vacant? And what's the impact on the 4 communities? While we look for someone with that experience, we're going to have to do some trading off, right? And that's.
No, I'm hearing you. But last question is, well, there might be 2. I would expect the salary is very competitive. Can you recruit someone from another town who has this work? So, yep. And then I just feel that I feel badly about it. And I know that oftentimes these kind of things are a personal, so there were two things, because Medfield is hiring and you told us the hourly rate. I don't know if that's been a consideration or feedback that I would expect it's competitive.
Yeah, we're competitive. Sorry, taking your questions. We're competitive. We're absolutely using our personal networks and, sharing the word. And, I've reached out to the folks in the training hub and said, hey, if you know anybody good. And, we're trying to work all of our possible recruitment strategies. Yeah.
How long does it take to, Donna Carmichael, I know did it. Is it like a year to become an RS? The trainings, I mean, I know it's amazingly broad, hoarding, but the core requirements for courses and then test, how long approximately does that take?
Off the top of my head, sorry to
Yes.
cut you off there, Carrie.
Go.
It's been 5 or 6 years since I did it, but at the time, I believe it's or still even, need to have bachelor's degree, 2 years of experience. And out of the bachelor's degree, you have to have 30 science credits. And then you have to apply for the RS, take the exam. So it really kind of all depends. And I see Sarah has her hand raised. I know she is pursuing the RS because her and I have talked about it. She'd know better than I would if she's actively looking at that. So did you have thoughts on that, Sarah?
Yeah, I was just saying that there's 3 different levels of an RS. Sorry, can you hear me?
Yep.
Yes.
There's 3 different levels of an RS you can pursue. There's level A, B, and C. Level A is if you have a bachelor's in environmental health sciences or a master's in environmental health sciences, then you are eligible to just take the exam and you get your RS. Then there's level B, which is if you have any bachelor's, master's degree in any field, but you have 2 years of experience, then you're eligible to take the exam and get your RS. Or, which is what I'm pursuing, is level C, is I have a master's in public health and I have 30 credits of science experience, but I don't have experience. Like I don't have 2 years of full-time work experience, but I will be getting 2 years of full-time work experience. So Class C is technically an RS, REHS training, but you have all the abilities and qualifications of an RS. You just, I believe that when you're technically still training, you have to resubmit for your certification. Instead of after the standard 5 years, it's 2 years. So there's 3 different levels and it depends on what your degree is in, what you've worked in, and how many years you've worked in that field. Sorry, I didn't mean to overstep, but I was
No,
quite
thanks
literally
for the
looking at this
clarification on that.
yesterday.
Yeah, thank you, Sarah, that's helpful. And I think I'll just add that I know that, there is ability to go to the licensing board and make a case that how you might fit into one of those if you don't have the 30 hours, but you have the work experience, that those categories are strong, but they are not. So they've changed it then, is that what you're saying? I see you shaking your head no, Sarah, they've changed it. There used to be some ability for petitioning, so no.
So you're not able to substitute work experience for the 30 credits of hard sciences. You have to have at least one college level math course. I think it has to be a statistics level math course or something along the lines of an R2 level math course, which is more analytical math. I think that's what it says, but I did look at it because I was trying to see if you can substitute graduate level coursework and part-time work experience, but you can't. So, because
That's helpful.
it said like you aren't allowed to substitute work experience for education. I'm pretty sure it's reciprocal, like you can't submit education for work experience.
Carol, just out of curiosity, what have you guys gotten in terms of applicants for your position? I'm sure there's probably a lot of overlap with this regional position we're recruiting for.
I am not the, on any kind of review and hiring. But at our last Board of Health meeting, Christine came and told us that, and Kathy McDonald on this meeting, that during this summer, they had paused, and I don't think I'm misquoting. So they felt that with the quiet and what's happening in surrounding towns with, especially this regional shared services challenge, they were going to be reposting. So I really don't have the statistics the way Carrie did, X amount of resumes, X amount of feasible candidates. But that was basically what I believe we were told, is that, you know, at this point in Medfield, there weren't any active consideration of people through that posting process.
Thanks. So, we will conduct our, we're doing our due diligence, we're conducting our resumes, based on the pool we got, and we will report back to y'all. And then for the assistant manager position, that is almost ready for posting. There's an additional piece of work that I need to do for human resources here. So that should be posted by, well, now I'm hoping maybe the end of next week. I'll get my piece of work done, and then we'll put that out. That is also going to be a tricky hire because, that we're requiring more experience, and they are both a trainer and assistant manager for both the training hub and the Charles River programs. So hoping that maybe that position will draw out some others. I will say I've had the opportunity to be working with Needham. They're hiring right now for a part-time environmental health agent, 10 hours per week. Pardon me. And I've been on their interview panel for that. And there were some pretty qualified candidates. It seems like maybe part-time work is more appealing to folks right now. And these were all folks who wanted to add, they were all working for part-time and wanted to pick up an additional side job to increase their experience levels, to increase their knowledge in the field. So we have been talking here about whether we can create a pool of per diem inspectors, much like there's a pool of per diem nurses that Needham has that they use for different things. We're talking about whether a pool of per diem inspectors might be feasible, and based on the folks that I saw, it's promising. I feel like there are some qualified folks out there that we might be able to include in our. Of course, we haven't asked them yet if they want to be per diem, and they may not. But trying to think creatively about how could we fill some gaps for the region, and take advantage of what exists out there. And it's been a good experience to be part of that hiring panel, so I do appreciate that. And I think that's it on hiring. We're kind of bleeding into my report, so then just sort of program and grants management. I have a few things. One of the things is medical director, which we've been trying to get resolved for a while, and Needham has taken the lead and pulled together an initial scope of work. Ginny and Julie, the EPI, I know did some work on that, and I know Jen Van Gatteren had a look at it. I think maybe with the other nurses. So I had a look. Tim and I need to just talk about it. We're trying to get that scope set. We do know that there are a couple of people who've expressed interest. And we're grateful for that, but we don't really have a scope of work yet, so we can't talk to anybody until we get that squared away. but we are trying, we are moving forward, and I appreciate Needham, you know, taking on that piece of work for us. Oh, and there's Tim, great timing. Is there anything you want to add to what I said about medical director, Tim?
I think I may have missed the last 30 seconds as I transferred from my phone to the computer, but
Just saying that, you know, I appreciate Needham having picked up taken up this piece of work of kind of figure out exactly what the scope might be and move us forward in this so that we can have conversations with people about whether the position, you know, the role would be suitable for them, and figuring out what is that, what does the person need to have or do? And I don't know, we were in a position where the, you know, medical director it was settled, right? It was settled business, or you know, the other towns didn't need one, and now suddenly like, oh yeah. And I know Kate Peterson in the past has raised the point of, well, how are we vetting people? How do we decide who gets to be one? So thank you to Needham for getting us moved forward and thinking about that scope. So stay tuned. And then other stuff on my, I know another piece of the work that we've talked about a lot in here is, you know, kind of outside of our direct scope, but absolutely part of the concerns for the towns is about using the opioid settlement funds and figuring out, you know, how maybe to move forward on that. I have two things. Through Growing a New Heart, who is the health equity vendor for the state, I have been told we have access to we can get a fellow, a student that will be able to do a little bit of support work on that. And Amparo Cruz is the person from Growing a New Heart. She said, yes, we definitely have someone who can support that. I haven't gotten a name yet, but I hope that maybe for our next August meeting, I'll have that. And then I know as well that in talking with Sarah Lappin as she joined Sherburne, I know that she has a particular interest in opioid work because of prior activity. So thought that was helpful, as this is kind of a little I'll call it a puzzle that the towns are trying to work on. How do we approach that? So maybe progress or slightly moving forward. Any questions about either of those comments that I just made about opioid? Anything else you want me to be chasing down? Carol, you're muted.
It's best that I'm muted.
Uh-oh.
Back to, can you just, the medical director, I heard the scope of work, Ginny, Jen, Tim, you, regional physician, people, a few people are interested, but you don't have a scope. Can you just clarify, that person would serve each town, or as a regional person for regional initiatives only? Or because the scope of work isn't finalized, you're not sure?
So I think Needham initially was just saying, okay, we need a scope of work, but I think it would serve everyone if we can find a person who's willing to do orders for all 4 communities. So that's our working hypothesis until we talk to people and decide to hear whether they want to do that. Tim?
I think so for procurement purposes, we need that scope of work, if nothing else. You know, we don't have a sense of what this should cost. The town of Needham historically doesn't do stipends in that sense, unless they're for like a full-time employee that has like an auto allowance. So we don't have like a stipended employee role. You know, do we want this to be a request for quotes where we have to accept the lowest bidder? There's something I think that I don't love about the idea of accepting the lowest bidder for medical advice. You know, so we have to sort of figure that out. I guess my thought is that if we had a medical director, she or he would service the region and service the towns within the region, but we would coordinate that work through the shared services. So like if Gail wants standing orders signed, Gail would coordinate probably through Jen and Kerry, and we would get that signed rather than saying, come to this Sherburne meeting this day, come to this Medfield meeting that day. We would try to probably coordinate our asks and streamline our asks. So like, if everyone needs standing orders signed in September, we would, put them all together, have a meeting and a discussion, and then get them done. So I think the idea is yes to all communities, but some amount of coordination and centralization.
That's awesome. Really awesome. So realistically, do you feel, since this scope of work is in progress, would this be something you would say, wow, our goal is to put this out in the next 60 days or
Okay.
Yes?
Definitely goal would be to put it out in 60 days. I guess my thought is potentially goal would be to put it out before the end of the month. I think, again, the question is, if it's over $10,000, it has to be a request for quotes.
Yep.
It can't be a request for proposals. Proposals would allow us to evaluate the experience, the quality, the ingenuity, whatever, of the applicant. So can we get it done for less than 10? Is that reasonable? I don't know if we know, is this going to be a great job for $10,000 or $5,000, or is this going to be a lot more work than $5,000 worth? I don't really have a sense. So I think in part, we kind of have to figure out, do we try to have like informational interviews with people who are interested, and then we solicit, I don't know, there's some questions, I guess, about how we would go about vetting a qualified professional who would be interested in us and we would be interested in them without running afoul of procurement law. That's all. And I think there's a way around it. I think we just have to sort of game it out.
Right. Because an RFP, if it's over 10, you have to put it out for bid.
Yep.
If it's under, you don't have to.
If it's under, we can go with a scope of work, provided, the vendor and us agree on the scope of work. And then there's other things like, are we paying liability insurance for the person, or are they paying it themselves? If they're a contractor, they should pay it themselves. I don't actually know what liability insurance costs, but they'd basically be building that into whatever they bill us. So if we're paying them $5,000 and liability insurance is $3,000, we're really only paying them $2,000, so some things to figure out.
Well, you're the guy to get it done.
Thanks.
No, I think it's really important, and I'm grateful to be a part of that. I know Kathy and our board would feel the same. So appreciate the clarification, appreciate Carrie and Jen and Ginny. Thank you.
Thanks. Any other questions on that? And I know, Jason, this was a topic that, looks like you've got plans in your hand, but this was something, have we covered everything that you were curious or concerned about? Yes, good, great, okay. And then, so opioids, waiting to hear, I'll have more news from Amparo. We had talked about, there was trying to do some work on a community health needs assessment that would support the full region. And there has been some work happening behind the scenes on that with BME. They were able to do some initial data gathering. We have some idea of what each of the communities has. I've had some conversations with Julie McCarthy, who's the EPI here on staff in Needham, and she is currently working on identifying what the questions are. Our goal is that the questions will be the same for every community. And we're less concerned about timelines or timeframes. People will have data of different, from different pieces, but we want to see if we can get a uniform set of questions that we could use in all the communities that then will enable us to get a baseline, move forward with an agreed upon set of data points, and see if we can get some more clarity on what the needs are, particularly thinking about the needs of folks between the ages of 18 and 64. Somebody taught me we call that the missing middle, because there's a fair amount of surveying for youth, and then there's a fair amount of surveying for folks over 65 and over. But we don't have a lot of reliable data sources or information that we regularly gather about folks in between. So that continues to move forward quietly behind the scenes, and I hope to be able to give a more clear update of maybe what are the questions, what are the topic areas. I'm targeting the September meeting. And the communications, that's a project, that's something that we identified as a priority. And I was able, with Jen Casey's help, we were able to get a contract with they're called Caravan Brand Consulting. And I believe they've been in touch with each community at this point, trying to schedule a meeting to understand what your communications capabilities and needs are. I think Michelle told me that she has meetings scheduled with Sherburne and Medfield today. So that's great, because, and the purpose of those meetings is to get info. They're going to build out some templates that then in Canva that they will then use, and they'll be doing training with each community to give you some info on how to work with Canva. They're doing templates based on what we hear about needs. So maybe it's flyers to announce. I know Jen G did a great flyer about Immunization Awareness Month. And then we talked about PowerPoints. We talked about, a newsletter potentially. So they're going to build some templates for us that we will use to build in on the, to then build on the training. And I know, thank you, Sarah. I see that Sherburne's meeting is next Thursday. And I know that we have varying degrees of skill in it. I understand that Sarah also has some skill in Canva, and that's great. And Jen G has been playing with it on her own. Thank you for dipping your toe in there and seeing what it's about. We've agreed that communications is an important thing for us, for the communities, getting the word out about what activities are happening. This contract is supposed to increase our capacity at the community level and at the shared services level to share info. And also it is providing us with kind of a library of things so that we're not recreating the wheel. Nobody has to go in you say, oh, I want to do a flyer for this. And has to go out and look for stock images and start from scratch. We'll have sort of a library of images that would be good to use. We'll have some standard formatting, and I'm excited that that is actually moving forward. I wish it could move faster, but any questions about that? Jen?
Not a question, just a comment. So just as far as the nurses with communications, I also have sort of a central place where anything, excuse me, I create for Charles River, like Carrie mentioned, the Immunization Awareness Month, that's going to be in a place where nurses can just access that material and use it, if they want to. And so I'm looking forward to having more training in it so my flyers can get better, but that's the plan for us to have sort of a hub.
Yep, right. Thank you, Jen. Yes, there'll be a hub along with the so it'll be a hub of policies and procedures, right? And sort of the workflows and but the hub also includes communications materials, and we're excited to start building that capacity. It'll include webpage too. We have here for both for shared services, we do have a webpage, and we're hoping to be able to start exploiting that, using that and giving it, maybe it's a thing that y'all can put a link on your website to say, oh, here's the information about how this works. And I'll say you know, there's two pieces to this comms piece. Part of it is being able to build awareness of what services there are, but it's also, remember, to build awareness of just public health in general and shared services in general, because we do want folks to understand that there's been a commitment by the state through dollars to support these activities, and want them to know how those dollars are getting used. And I've got a couple hands up. I think, Sarah, you were first.
Actually, I think Carol was first because I saw her hand up and then I raised my hand. So if she wants to go first. but
Sure,
I don't know if I
just
care.
so,
Sorry, give us 1 second. So there's, I had the door cracked, and part of the fun of sharing space with Parks and Rec is that there's all sorts of energy happening at different times, and there was just a big excited gathering happening out there. Okay. So what
this
were you
is
saying, Sarah?
awesome. Whoops, sorry.
No,
This
no.
is amazing. And so Caravan is the regional communication consultant that is meeting with each town
Correct.
to identify communication needs. In a town, I think that's awesome. What I have felt, since our particular capacity is limited and we're building a staff, that this group can create those messages for us as a region for health, mosquitoes, whatever. So did I hear you say it's two things? This person can work with each town as they're ready, and they also will be creating messages like Jen has for nursing that are going to go out for towns, maybe through public health or town website, about health alerts or, DPH stuff. So ours is more that in real time, what the state is telling us, and it's a vetted, thoughtful message. Because right now in our town, there's not the staff to do that. So there's two structures here.
So, right, your question, I've actually been talking with Jess Furland, who's our point of contact at the state for our funding, to inquire about how other shared services arrangements do what you describe, or do they do what you describe, Carol? And what Jess's initial guidance has been, making sure that everyone in the advisory board and everyone in each community is signed up for the messaging from the state, that they receive the alerts from Office of Local and Regional Health, and that they attend the monthly OLRH, I call it the radio show, the presentations that they do, the special topic seminars that they do. That's her initial recommendation. And I think that the question is there a next, how do we then knit it together, and do we have the staff capacity to knit it together and do communications work? We can do some, Jen has already done some, right? I think what you're talking about is a little bit more, well, I'm not sure. I guess I'm not entirely sure, because like most things, it falls within maybe nursing wheelhouse. It's, cases of West Nile virus. It's, increased awareness of, need for vaccination for this. So those are, it seems like maybe you're talking about something else, but maybe you're not.
It may fall on nursing and Jen, because in real time and advisory through DPH for health or anything, heat, smoke, all that stuff. I guess I'll say that individually towns can work with the consultant and develop templates and flyers as they're able. And Jen is putting together a hub that has information that the nurses in each town can access that are standardized and vetted messaging to inform residents. And then it will be how that gets distributed in each town is town specific. But it won't have to be created.
Sort of. The consultant is creating templates that everyone will use. There's not going to be custom templates for individual communities, right? The work is identify what are the standard templates. And we're talking about, again, it's about the mode of communication. It's not about the content. It's okay, we need to do a flyer to announce something. It may be a flyer asking you to show up for a clinic, or it may be a flyer saying, there's increased smoke from Canada. I don't know. There'll be a PowerPoint template. There'll be a newsletter template, and beyond that, they haven't completed their work of talking to you all. So I don't know what other templates there might be. That's what they're gathering. They'll identify the common needs, and they'll create those with space for logos and understanding sort of, here's the audience, here's the message. So we're going to get some communications training and a pool of templates that will be suitable for all 4 communities to use, plus shared services that we'll all have access to. I'll be asking to adjust our budget a little to pay for Canva accounts for the communities, and we'll use that. But I'm a little ahead because I need the recommendations from the consultants before I can move us there. So I think
Awesome.
I'm kind of saying the same thing, but perhaps not exactly.
That's great, and thank you so much.
Okay. You're welcome. And then Sarah, did you want to add something to this?
You actually kind of answered what I was going to ask. It was about because Shared Services is providing this training, if they would be funding our subscriptions to the Canva Pro service. But you did mention doing some budget reworking. Sherborne, actually, we just got our own subscription because that's been an initiative of mine as I've been working here to have Canva Pro. So once Shared Services, I guess, figures out the funding for that, we can talk more. But that was my question, was if Shared Services is going to be providing funding for that.
Yeah, I think we'll have dollars. Our budget was quite tight, as folks will remember when we were looking, but we knew that we would be having dollars because we have empty positions, and I think it'll be, it's an easy thing for me to recommend that we support that, but I do need the guidance from the vendor before I say to y'all, here, please, this is how I want us to adjust the dollars. But yes, that's my plan, is that we'll pay for Canva accounts for the community so everybody has access to the same thing. And it may be, well, we'll figure out the mechanics of it, but yes. Okay.
Thank you.
Yeah, thanks. So, and I'll just note, Ed Cosgrove had to leave at 10, so thank you to Ed for being here. And thank you, Tim, for being here as well, so that we retain our quorum and can continue to do business. Okay, so I think my last update is kind of on that same vein. So one of the things we're thinking about is we get notices about trainings and the like, and I want to figure out if there's a way to streamline passing information to you all. I don't like just to overload inboxes, but I get things. For example, I got notice of a potential hoarding training, and my question to you all is, do I send those notices out to the advisory board list whenever they appear? Do you all want to designate someone in your department that should be receiving those things? And then I'll know that they're doing their work to pass it up through their board or supervisors or both. I could forward you emails all day, every day. It wouldn't be a great use of my time, and I don't think it would be a great use of all of your time. So I'm looking for a little guidance from the communities on how you might want to manage that. Carol.
Kathy will be back next time. In the
Hello.
past, I read your emails. I don't reply to them all by any means, but two things. In the past, it went to our office manager, Nancy Benatti, and our chair, so that the chair would make sure it's mentioned at our meeting. So I would expect our board would say, we like that to
Okay.
continue. But two, I like when, you know, I don't think you'd be emailing us every day, all day, but synopsis things I feel are really valuable. I've always been on the OLRH monthly webinars, but our other members haven't. So coming from you and shared services, I feel is better than me forwarding after a meeting. So a synopsis email, I feel, is really appreciated from you, who's the expert and who can, you know, sort out what we should know, what we shouldn't need to focus on. And again, to our office administrator and our chair. That's what's worked for us before. Thank you.
Okay. Okay, so that's Medfield. Anybody else want to weigh in on how they might like to hear stuff? I can send to, just like we're doing with Medfield. Yes, as she said, as Carol suggested, I could send to the chair and the administrator or me in Sherburne, in Dover. Jason, I don't know if you want to get all that, or Tim, how you might want to.
Personally, I already get them all, and then I also get them from our distribution list for health at Sherborne. So I don't need it 3 different times, but you know, that's just me.
Very fair, and and that's exactly what I want to hear. So Sherburne, you feel like you're kind of well supported. You don't need forwards, but Carol's suggestion about synopsises, is that something you're interested in?
I mean, I'd read them, but I also read all of the OLRH emails that I get and the MDPH. I mean, I read all of them.
Yeah.
Honestly, sometimes they help me fall asleep, so.
Okay. Okay. And
I guess I would add,
go ahead.
I did raise my hand, but I just wanted to add to that the idea of a synopsis can be nice, but that's also work, extra work for you. So I just don't know how that fits into schedule of staff at the CRPHD.
Okay. Thanks, Daryl. Dover or Needham? Agnostic. Looks like Jason may be busy working on something else too. But
No, I was just gonna say, Carrie, I'm good either way. I'm very go with the flow. So
yes, you are.
That's true.
Thanks, Jason.
For me, I think I guess I would sort of, in Daryl's comment, just find the balance between this could be helpful versus how much extra work is it, in terms of doing additional synopses. I guess, maybe every once in a while there might be a particular point that's worth summarizing. I just wouldn't want that to you know, I don't know. I'm not sure that's the most valuable use of time sometimes.
Okay. Okay. Great, thank you for the feedback. I think what Carol's raising is it's wanting to make sure that everybody is receiving the information and getting it's kind of on the same page because we're all operating in a similar environment. And if everyone is signed up and getting the alerts and feels like they're well communicated with, then we can have conversations that are on equal footing. And if there's a barrier to getting the info, that impacts whether we can make decisions or whether people are making decisions, with all the information. So, we'll go with the making sure that the chair and for Medfield, I think particularly in their flux right now, we'll go with that. And kind of trust that everyone is on board and that when there are topics that you maybe get a communication on that you want more info, that you will reach out to me, and say, can we put this on the agenda? Or, maybe it's not an agenda item, but maybe it's can we talk about this? Or the nurses are talking about it already and they're going to tell us about it. That's what I'm taking away. So thank you. Okay, so we're a little past time on the agenda. I want to ask if there are. I have next up the work plan and the strategic plan implementation. I feel like we touched on some of those things now, and the other item is the community updates, questions, and concerns. I want to leave space for communities to make announcements or share information or share, plans or ask questions about other activities. Do folks want to move first to that community update section and then we can catch back up on the work plan? Or would you like me to proceed with the work plan? I don't like listening to myself talk a lot, so I'm happy to hear y'all talk too. Does anybody have any questions? I'm going to say, all right, so I'm going to throw it out. How about vaccine? Anybody have any questions about vaccine? It's a big question right now. There's a lot of question marks. I don't know how many folks were able to be on the Public Health Council meeting yesterday. It was a very interesting conversation, scoping out. I say this is, and I'm not a math person, but I say we've got a big calculus problem where we've got a lot of unknown variables right now, and we're trying to work to make more of those variables known. I think one of the big concerns I've heard folks talking about is in the current environment, there's a question about whether insurers will cover administration of a flu or COVID vaccination for everyone, for anyone, and kind of how do you implement the restrictions, and that opportunity to bill for it, the ability to have those costs covered, it makes a big difference for departments. And I think that's kind of the pause. Am I saying that accurately, Tim?
I think so. I think in any given year, there's always some unknowns, and partially that is their interest, right? Interest can wane and wax, and sometimes there's a bad flu year and that prompts interest the next year. Sometimes there's a flu year where the vaccine is a very poor match for the strain that actually is in circulation, and that, prompts some people to, sort of throw up their hands and say, I'm not getting a flu vaccine this year. But that's the case every year. I think this year, the question is, or the concern is, we have the additional variable of, I guess, the general sort of up and down of how many people are interested, what the sort of political tenor does, is there renewed interest because there is sort of a relatively concerted federal effort to discredit vaccines, or does that actually, so, is that successful and therefore people are less interested in COVID vaccines? Or does that renew people's interest in vaccines because people are trying to take them away? And then the what is covered. And is there a way to, yeah, I would love for insurers to come out and proactively say we are going to cover vaccines for everyone, giving those people, the insurance companies, some benefit of the doubt. It does seem like when people take a firm stance against the Trump administration targets them. So I don't know that if I was Blue Cross and Blue Shield, if I was Blue Cross and Blue Shield, I would cover all vaccines. I don't know if I would say publicly state I'm going to cover all vaccines. The risk then is, and we're relatively fortunate, I think, in Massachusetts, given the number and type of insurers, but it's a lot of money to be out, roughly $20 to $30 a dose for flu vaccine, depending on what you get for costs, 100 to 150 to maybe 200 to 300 for COVID vaccine. So if you're not reimbursed for that and the administration, that's a huge financial challenge. I've been kicking around sort of what are some technical ways to try to do it, because insurance companies don't have an easy mechanism by which to sort of verify whether someone is high risk. As I think Jen G noted, if you take the broadest sort of definition of higher risk or eligible by age or medical condition, it's a majority of the US population, 60-something%. Is there a way to sort of say, as you register in color, I, by the way, am high risk for one of the following reasons, and I don't have to specify which, but it's just one of these, smoke, don't get physical activity, overweight, immunocompromised, all these things, and send an automatic email to the insurance company, and maybe that's enough to put it in your file that they're like, okay, well, we should cover this. When we get an insurance claim, we'll click approve. Or is it when you register online and you come in person, we have you sign a document that we keep saying you're certifying that you are high risk and therefore we are giving you a vaccine. And if the insurance company rejects the claim, then we say, okay, we're going to send you this big batch of files that, is, 100 people that are certifying that they are high risk. And that's what we were operating on. And that's what we think you should operate on. And therefore you should reimburse us. I think there's a lot of things to try to figure out. It does seem, just from my perspective, the advisory committee on immunization practices was, and it's been in place for a long time, was bipartisan or, nonpartisan really. And it replaced a former system that was kind of disjointed where different, medical societies, professional associations, et cetera, would have different recommendations. Most of Massachusetts health coverage insurance type regulations essentially defer to the federal guidance and the advisory committee on immunization practices. They never sort of put an out in saying, or the commissioner of public health can say X, Y, Z. And it's easy to look back in retrospect, but at the time, no one sort of thought this type of work to discredit vaccines would occur. I don't know. Now I've been talking for a while and I'll be quiet.
Karen? Karen? You're still muted, Carol. Oh, there you go. Take a breath.
So for a layman, are you saying, I was not on that meeting, that as of today or yesterday at the Public Health Council meeting, our state is following what the CDC said, 65 and older and high risk? That's part one. That's like, that will be their recommendation. I'm not even talking about, say, COVID, just this season flu. Is that what they decided? Or is DPH going to be more detailed?
My understanding, and there were other people that were on the webinar as well, so please jump in, is that they haven't reached a full conclusion. They would love to have sort of a unifying federal set of guidance that isn't determined by people who aren't vaccine experts. But to me, that sort of is relying on someone to come to the rescue. There is legislation that was introduced that would basically say the Commissioner of Public Health can kind of, make decisions to override or, establish what the appropriate minimum level of vaccine coverage should be for all insured persons. I don't know. I have no clue legislatively, how big a priority that is, how quickly that could happen, et cetera. So I think the state is in kind of a, we're not exactly sure what to do. As an added wrinkle, Michael Osterholm's group at CIDREP at the University of Minnesota, the Center for Infectious Disease Research and Practice, has kind of formed Shadow ACIP, where they're basically getting together experts to sort of try to make a, ACIP-like recommendations and understanding about vaccine safety and so I think the answer to your question is not that they're accepting the federal guidance yet. It's that they would like to have a better process and come up with recommendations. Carrie, how would you describe that from yesterday?
Yeah, no, I think that's right, Tim. I think I'll do I understood from Dr. Osterholm's presentation that the Vaccine Integrity Project is double reviewing all of the literature out there and emulating what the ACIP process is, and will be distributing summaries. I'm not sure that they're actually going to the step of making recommendations, and that's part of everyone's concern, is that we're trying to use a system that hasn't had to operate together. So they don't want to make recommendations. They're providing expert summaries that they would be distributing to medical societies in the different states for their review. And a lot of the conversation was about, how do we avoid the dilemma of different recommendations from different states? Is there a way to pull this together? Again, this is a structure that does not exist. It never had to, because ACIP and CDC were providing that mechanism that everyone recognized and operated with. And now those entities aren't as reliable. And I think there was one former member of, maybe two members of ACIP, one who left before everybody got fired. And they're very much in favor of the work of the Vaccine Integrity Project, but nobody quite has a solution yet on how to pull everyone together. Dr. Osterholm was giving a lot of props to Dr. Goldstein, Commissioner Goldstein, saying Boston has the ability to kind of convene and come up with solutions, and that's great. So we've got a dilemma, and I think Commissioner Goldstein made a very strong statement, and on behalf of the department and also on behalf of the state, that Massachusetts, supports vaccination and understands that vaccination is not just about the logistics of getting shots in arms. It's also about, I think the quote was, it's also about justice, and it's about making sure that people who need access to vaccination have it. And I appreciated that. I came off kind of feeling, oh gosh, we're still in a bit of a pickle here. We don't know quite where we're going. But at the same time, I appreciated being in a state that was able to stand forward and say, yes, no, we're going to figure out how to deliver this. But we don't know what insurers are going to do. So I don't know. I don't know if others want to say anything about what they gleaned from the call or from other things that, you know, they've read or conversations they've been part of. I know we've got a couple nurses on here that have probably been part of conversations. Oh, I see Jen's hand up.
Yeah, I just would add, you know, I think Ginny and Julie and I eagerly went to the meeting hoping that we would leave and there would be some like official guidance. And just to echo what you said, it sounds a lot more complicated, in especially the messaging, because I think people are getting their information from so many different sources, and some of it is accurate and based on science. And I think, like what the commissioner was saying about, you know, you don't want to have Massachusetts saying one thing and then New Hampshire says another, and Vermont, you know, the surrounding states are giving a different message. So, you know, I do think the messaging and getting out accurate information to people is part of that.
Thanks, Jen. Carol?
So the data doesn't change on past. If you get a flu shot, you are X likely, whatever. So what I heard you say is, and Tim, Dr. Goldstein, there may be a legislative piece that we can, in Massachusetts, like make a law or that would compel insurance to cover. I don't.
No, I did not, that's.
Tim
It's
said.
not what I meant to say. I think, you know, there is interest at the state, there is a commitment at the state to the importance of vaccination and figuring out how to provide vaccine to the people who need it in the face of organizations now, you know, national organizations now, working against vaccination in some ways, and the question of, in that environment, what happens about coverage for it, right? Whether insurers will cover it. I did not hear anything about legislative action, and I wouldn't want to put that in
Your minutes.
I did say that though.
Oh, you did. Sorry, Tim.
There was a bill that was introduced in
Okay.
mid to late July. I don't know where it stands on Beacon Hill. There was a Globe editorial about it as well.
Okay.
Sort of saying like why should we hitch ourselves to Secretary Kennedy? We should, you know, if they're gonna disregard science, we need to have an alternative process. I don't know, you know, who's sponsoring that legislatively. I don't know if that is something that could happen expeditiously or if that would be a drawn out thing. But basically all of the insurance regulations in the state tie back to sort of ACIP rather than giving an alternative pathway that's like, or the state process if we decide it's better. The state did have a meeting, and this wasn't on the call yesterday, but it was in the Coalition for Local Public Health meeting on Monday. The commissioner and the Office of Local and Regional Health did have a meeting with basically all the insurers in the state. And this is important to distinguish. The only insurer that basically said it would reimburse automatically for COVID vaccination for all populations was Mass Health, so Medicaid.
That was my next question.
Every other insurer, even nonprofit insurers like Blue Cross and Blue Shield, would not commit to reimbursing for all populations. That is not the same as saying that is not the same as actively saying we will not cover it, but they were not willing to make a commitment saying they would cover it. So that's a big question mark, right? And if you're a local health department buying something at $150 or $200 a dose, that's a lot of money to risk if you don't think you're going to be able to get reimbursed.
So the other day for COVID, on this call, Medicaid said they would reimburse for COVID for anybody who wanted it, or for those.
Anyone who is they said they would do for anybody. They didn't need, they wouldn't just restrict it to 65 plus. They wouldn't just restrict it to they would let it happen as it has happened in the past.
Okay, so that's good. And then,
And we
but
know the
private-
insurance companies don't have a mechanism to verify really who is high risk or not. They know some people are high risk. They don't necessarily know that I'm smoking a pack a day of cigarettes or that, you know, I'm physically inactive or something like that.
Yep, but this is COVID, not flu.
Yes, in the context of COVID, sorry.
And so right now is time, you know, when every year working with you and your department and helping out, it's time to start saying, we're going to have clinics. So right now, what you're saying is for flu, there is no commitment to reimburse for Massachusetts residents who register on color. I heard exactly what you said about indicating high risk and then maybe coming in and signing a form and then you batching it together, which is, you know, always above and beyond, and most towns aren't going to do that or counsel people to that. So right
So
now,
it's a
people
little,
don't have approval to pay for a flu shot, even at CVS.
so sorry. I think there is some ambiguity about flu. There's a lot of ambiguity about COVID. So we think that flu shots will still be covered for the majority of the super majority of people. But, you know, as a comparatively healthy 43-year-old, in theory, insurance might balk and say, no, you're not 65 plus, you're not immunocompromised. Mr. McDonald, I'm sorry, we're not going to reimburse anyone for giving you a flu shot, COVID shot.
But for flu, we think flu will be covered for the majority of people.
Yes. So we think flu is basically the same as last year. We think COVID is very different.
Yep.
In Needham, as a reference, 2 years ago, we did about 750 flu shots. Last year, we did about 520. We returned about 200 something doses. We managed to give away almost all of our COVID shots, except for a handful, but it was a lot of work to sort of track down people who were willing to take them. So that's part of our calculus of like, okay, now that there's a federal attack on vaccines, is it harder to get people, or because there's an attack on vaccines, are more people like, I need to make sure I'm one of the people who gets this?
Mm-hmm. I'm sorry you're dealing with all this, that we all are. And, you know, people ask us, and look, you know, our Board of Health, you're in Shaw's, and people will say, oh, you know, are you guys doing a clinic through the pharmacy? And, you know, I just want us to be able to reflect, you know, so if people ask us, we're saying flu seems to be following the same path and reimbursement as 2024. But COVID is TBD, except for Medicaid covered people.
Yep.
Yep. Nicely summarized. Okay, and yeah,
Thank you.
I see I see your face, Carol. I read it. It's a little bit it's hard, right? It's just it's hard. But we're all, I guess maybe the good news is we're trying to move forward, right? We're identifying conversations and identifying paths forward. You know, the fact that the Public Health Council convened and had this roundtable about it, you know, that's good. There's nobody's just saying, oh, okay, this is how the reimbursement's going to work, and we're going to just work with it, right? That is not the stance here in Massachusetts, and that is that's positive. So we're going to have to continue to deal with the uncertainty and ambiguity, and just know that there are some other folks that are thinking about it and trying to figure out how to make it less ambiguous and advance public health. So, and I think, you know, I'll tie this straight up to our work plan, right? One of the objectives that we have selected is about increasing vaccine access. So, this is direct to our work, and we're not the only shared services group that identified that. So I know it'll be a further conversation on our regular meetings with the other groups. I just think it's important that we kind of talk about the complexity of it and not just focus on okay, we're gonna host them. Yes, we're gonna host clinics. Thank you, Jen and the other nurses, for figuring out how to do that. And we're also looking at what are some of the questions about ordering to meet that. And then I think I'll pivot us back to the work plan. As I said, we've been talking about a lot of things that relate to it. One of our objectives is communications, increasing awareness of shared services and of public health. And we've talked about that. We're talking about improving sharing of another objective is improving sharing of services. And I am doing this verbally. Usually I like to have a visual aid, but I only have the smart sheet right now. And the smart sheet I feel is more confusing. So thank you for bearing with me with just my words. I'll have a visual aid for you next time. Improving sharing of services, we're clearly making progress on that as we talk about on the nursing side, and we were in great shape with the environmental health side, and if we can get some hiring done, then we'll continue that. And I think broadly, contributing to each other and hiring panels and thinking about how we solve the issues of lack of staff. And thinking about the communications piece, that's a sharing of services as well. One of the things we wanted to do was start expanding community partnerships and thinking about who are organizations in towns that we can do that with. I think that'll be a natural outcome with vaccine clinics and with the public health nurses, but I'll be working with Jen and the others to kind of see who are we working with. We'll use some of the data from the Foundational Public Health Services surveys that we gathered of who are the organizations that people work with in town. So we'll continue that. Addressing the gaps in performance standards. You'll recall the performance standards are the legislative and regulatory requirements in Massachusetts for public health. And that's what the Environmental Health Group was working a lot towards. And we are at 83%, and we want to be at 100% because that's the floor, right? It's not the ceiling. It's not we're not at 83. We've got a good solid B. It's that you pass at 100%. So and the barrier, the things to get us to 100%, we're small. We're real, but we're small. So I think we'll continue to make progress on that. Next objective, disease control and prevention. Using proper case investigation protocols, and we're definitely doing that. And I know that I'm going to be asking Jen Gengadarin to do a little bit of presenting to us, maybe at our next meeting, about here are the standards, just so everyone's on the same page. Here are what the standards are for case investigation. Here's what the expectations are, and here's how our communities meet that individually and together. Tobacco prevention, that's been a big priority. We do have it as a objective for this year, and we'll be looking at so a couple questions. Can we and do we want to collectively implement tobacco compliance activities in all communities? Do we want to consider applying for funding when it becomes available to be a tobacco collaborative? I'll be able to share information about that. The vaccine access I already mentioned. Assessment and surveillance, using data to try and create public health programming that maximizes health outcomes. That is both environmental health and nursing, and I do think we're continuing that work. And then the last objective we have is inventory management, and that we're able to build on some of the work that Sam did on the training hub side, if before Sam and Amy did on the training hub side of implementing an inventory system, and we're gonna use that system, and we'll be able to offer a little demonstration for y'all of how we're tracking things. It includes the information about what's in the lending library at the training hub. And we can track for audit purposes and just for good management. We know, okay, these are the things we bought and here's where they are, and here's when we bought them, and gee, maybe we're running low on chlorine test strips and we ought to think about buying some more of those so that we're making logical decisions about how to spend our dollars as we look at, do we have available salary dollars to spend, where are the needs, and be able to run that past y'all and say, yeah, no, it makes a lot of sense for the shared services group to be investing in the chlorine strips because we can get a better price for it if we buy it in bulk as opposed to one community buying. And now I'm starting I'm going to stop with that improvisation because I'll start making stuff up. But the inventory control things, I think that principle is there. So those are our objectives. We do have some requirements from the state in terms of participating in Metric, which is the data solution, participating in the rollout of it. I'm on a user committee for it. I'm going to be part of a testing thing, so I'll be able to contribute to that. And there will be more information as Metric gets better developed. And we'll have to have further conversations about what are Metric capabilities and how do folks want to use it. It will impact funding questions because one of the outstanding things will be that when Metric is fully rolled out, it will no longer be an allowable cost to pay for the inspection software that we have. So down the road, we'll have to be, considering what Metric has and does it meet needs? Do we need to, and how is the inspection software a important expense? How would that expense be covered if we can't use shared services dollars for it? And I need to do a presentation to each community's Board of Health about our strategic planning process. It was a requirement from last year, which I got a little extension on because we didn't finish our work until June, and said, so I can't do a presentation in June because we're not finished. And they said, that's fine, you can do it in the fall. So I will be reaching out to each of you to ask for a time on the calendar, and I'll share a presentation with y'all in advance so you can see what we're talking about. It'll be a nice opportunity for sharing info about what we do, and I'm always happy to come to anybody's Board of Health and talk about shared services and entertain questions and get feedback on what community folks think we ought to be working on. So that was kind of a quick thing, but it looked like people were making notes and nodding, so I think I was making sense. Any questions? Carol, I see you got your hand up.
Just a clarification, because
Yes, ma'am.
I am trying to take notes for others. You mentioned through BME, I believe, community health needs assessment that will have uniform questions.
Yep.
That in the future will identify, and I think you said focus on age 18 to 65, because most of us have the Youth Metro West Health Survey. So is all that, so BME, Community Health Needs Assessment, working on uniform questions to create a survey for 18 to 65. And if that's all right and accurate, will they, BME and you or whomever, coordinate with BID Needham or Newton Wellesley Hospital and align with their every 3-year process of community health needs assessment so that we can get money? Anyway, from the hospitals, community benefits. So if I was accurate, great. And then is there a plan, or because I know we all work hard to get our residents to participate in those community health needs assessment efforts, focus groups, surveys.
So yes, and I think, so the first piece of work for BME was to establish kind of what's the baseline, what data does everybody have about everything? And that's what I want to see from them first and be able to share with y'all of, here's what we know and here's what we can combine across communities. Here's where we don't know things. And then the next step, so we're approaching this next step of what are the questions? And I think Julie is starting to have conversations in Needham of what are the things that we think we need to start inquiring about. She's talking with different groups. And so we'll ultimately be creating some questions, and we will be sharing them and asking folks to figure out how will we do some surveying. As far as aligning with BID Needham, right now we're trying to be timeline agnostic, right? We're trying to gather data that will be useful, that would certainly align with any community organization that might be interested in or developing programming related to health outcomes. And we're hoping that we can contribute it and show it to other organizations. I trying to get us all on the same timeline. That's next. Does that help? I mean, so your interest is wanting to have data that we can share with BID Needham that would demonstrate that we have a need that they might want to fund? Did I understand you?
Well, no, I feel that by law, Tim can correct me, we've always, as a staff person, even though I work on grants, we've been at public health has to be at the table in planning the every 3-year process of the community health needs assessment. And the questions have been quite standard, where they get the information, there's limited treatment data, all that, everything of this, So to me, it's almost like that's process, and those reports are valued, and the sources have been reviewed and valued for that 18 to 64. So is BME going to align with that? And, are you making new questions? I just know that it's a time intense thing. And this work has been going on for a long time, and I'm asking about alignment. It's like, for example, the state has a youth risk behavior survey. So schools are asked to do that. And then we have in our catchment area 25 towns that do the Metro West Adolescent Health Survey.
Mm-hmm.
When I worked with 4 or 5 towns, they don't want to hear any more surveys. So the questions are similar. Will BME, and I didn't realize this because I don't pay attention as much as I should, be looking at and aligning the questions with what has and maybe asked in a year or next year. I don't know the 3-year schedule for either Newton Wellesley or BID Needham. Norwood's closed. And any of that data can be used to apply for funding from any of those hospitals. Doesn't have to be from their CHNOP process. So
Okay. Thanks for clarifying. Yeah, so I mean, yes, I think, yes, that's part, yes. The work is what's the existing information we have? What are the sources of information and where are the gaps? And the new questions are to be for where there are gaps in questions being asked. So yes, I misunderstood. I thought you were talking about the timeline of their process, and it's not, it's what information is being gathered. Yes, BME is looking at what are the information gathering mechanisms and not wanting to duplicate any. But yes, also acknowledging that there are questions that don't get asked that we want to figure out how we can gather info. What's the right question to ask so that we can fill that gap?
Right. And, there's quantitative data on treatment through DPH funded.
Yeah.
Yep. That's one thing, and incident data, but then there's the focus groups, and I just have found it valuable to see what they've done and over the years and
Yes.
align with those.
Yes, that's exactly what BME's doing. Yes, it's relying on existing data sources, mapping what they are, and then identifying where are there gaps of information. We're looking at the foundational public health services as a framework of, okay, where, people are asking questions, but, do we have reliable information about access to care, for example? Do we have reliable data sources about maternal child health? So that's what this process is about.
Mhm.
You look puzzled.
No, I was just
Okay.
thinking of something commonly, and I'll promise I'm going to mute myself, is our towns being connected and paying annually for the interface, William James.
Yep.
We need a therapist thing, and they just, it's costly. We can't all sustain it. And, is there something there that's common across our 4 towns that we can identify as a need, but then maybe advocate collectively to get funded? Just one
Right.
example. No,
Right,
it's
exactly.
important, and I appreciate the work.
Yeah, I mean, and that's exactly the kind of, what we're hoping to get, the goal of getting the info is so that we can have those conversations, right? Everybody's paying for this. This is the data we got about how it's being used. Yes, I think we're on the same page. Okay. Anything else? Tim, was there anything you wanted to add to that conversation about info gathering?
Sorry, I had stepped away
You're
very
fine.
briefly, so no, I have nothing to add.
Okay, that's fine. That's fine. Just, I know you were, okay. All right, anybody else? Questions about the info gathering, about the objectives, about our path forward? No. Okay. Everybody's happy. I love it. Does anybody want to make a motion to adjourn then, and with our next meeting being held on August 26th, which would be a Tuesday?
I'll make a motion.
Okay, motion from Jason from Dover for adjourn. Is there a second?
Second.
I see a second from Carol Reed from Medfield. So then we'll do a roll call vote. Dover,
Yes.
Medfield,
Yes.
Needham,
Yes.
Sherburne.
Yes.
Great, thank you. Then we're adjourned, and we'll see y'all on Tuesday, August 26th. Thank you for the time.
Thank you for your
Stay
patience.
cool.
Hi, everyone.